I think we're going to go ahead with the next session, I have a pleasure to introduce Dr. Alisa Limsuwan. She's currently an associate professor in pediatric cardiology division at Ramatipadi. She graduated from Chulalongkorn University in Thailand here, same as I do. And she did a residency at Michigan State University and went on to do a pediatric cardiology fellowship at University of California, San Diego, and now returned to be a staff attending at Ramatipadi Hospital. So she's in charge of reviewing the USMLE course on pediatric cardiology. And without further ado, we'd like to turn the podium to Dr. Alisa.
Thank you for introductions. Well, I know that the morning section is conducted in English, but what I prepare is I bring up a lot of tests and questions. I prepare like a 280 slide within 120 hours, so I have to go like a 2 or 3 slides per minute. So I would like to ask the audience, do you want me to conduct in Thai or in English? Thai, if Thai, raise your hand up. Less than half? Really? English? Or both? Seems like Thai is majority.
Yeah, actually, just to FYI, Dr. Somkit actually prefer us to do in English because they're gonna have a DVD, so this will be an opportunity for them to review it later on. So a little bit of Thai, but mostly probably be best so for the student sake in terms of practicing learning in the future.
But my standpoint is if I conduct in Thai, they may get more information from me. Basically, I will not review the knowledge because you all have the knowledge. I'm gonna give you trick how to take the exam to get the maximum score. And what is a question they love the questions most in the exam in medical school system in America. It's somewhat different from what we ask questions in Thai board exam. All right, so I'm gonna start with question. So when I face the questions, I'm gonna scream to the questions. This is definitely pediatric questions. In pediatric case, you have to look at the age of the child because the different age gonna give you different diagnosis and disease. Well, 7-year-old girl found come to the clinic visit with bilateral breast tissue development, and she also have a pigmented hair overlay being measured. Her height weight on the 80th percentile for age. Which of the following is the most appropriate management? So this is the STEM. You look at the scenario and look for what they're asking for the management. So, okay, I did not quote this for the PowerPoint, but anyone from the audience would like to give ideas? What's gonna be your answer for this question? Anyone at all? C. Right, I heard that C. Anyone else? Do you think C is the correct answer? Yes or no? Please. There's no right and wrong here. You come here to practice, to encourage, to just be like expose yourself to question. Actually, as I mentioned, I have like plenty of questions. I have like a PowerPoint for 10 questions only that what they asked me for. Otherwise, we're gonna running out of time. What do you want to do now? I don't think they're set up. Excuse me. We can try. No, okay. So, sorry, the system is just set out for 10 questions only. Sorry, that we cannot do that now. All right? ไม่เป็นไร cancel ไม่ต้องตอนนี้ได้เหรอฮะ Okay, you want to try the PowerPoint? So you can do something. Okay, the answer is C, and C is the correct answer. Do you know why? So it seems like in this scenario, the girl have like a design of precocious puberty, right? For 7 years old, is it fit the criteria of precocious puberty? Do you remember the criteria? Basically, the definition of precocious puberty is the sign of puberty appear in girl before the age of 8. However, for the age of boys, difference is 9 years of age. So in this case, 7 years old with this sign show that the girl have precocious puberty. And the reasons we do that a radiography of the head and wrist because we want to do bone age. Approaching precocious puberty, you want to know what's the age of the child. Is it chronological age, delay age, or advanced age? Because the differential diagnosis is going to be different. So majority of the time, the girl with precocious puberty, around 80%, they'll have like, is caused by the idiopathic. That means we could not find the reasons. Some of them may have like a hormone-producing tumor, and some of them may have some other conditions. So in the first initial management, you do the bone age. So this case scenario can be asked as a question for the board or sub-board exam, but they will ask you in different way. The same scenario can ask questions for medical student, resident, or even those sub-board. So the scenario pretty much the same, but how far further in detail that they want us to answer the questions, that's the different level. So in case that you can find any exam question, you can try and take a look in the question type and what source of the disease they're asked quite often in the exam. Next one. 12 years old girl. So when I see the questions, I'm gonna just like a screen for the keyword, right? So in this case, 12 years old girl, sore mouth, feeling poor, fatigue, weakness, already have menstruation, breathe and then stop, exam facial white clustering on the oral cavity, biopsy show candidiasis. Laboratory as follow: sodium 127, Ka 5.3, bicarb 25, calcium 7.5, phosphate 5.5, glucose normal. Which of the following is most likely diagnosis? Do you want to try power board again? Seem like you like to do it. Okay. So a majority of you answered choice B. That means multiple endocrine neoplasia type 2A, right? And followed by choice C. That's the polyglandular deficiency syndrome type 1. The answer is C. So this is the questions that they love to ask. Despite that daily practice, you won't see that quite often, but you have to remember, right? Your sense-wide, they love to ask that men that multiple endocrine neoplasia. However, this is the symptoms of the child who have the problem with the endocrine deficiency. All right, so you may not heard, I'm not quite sure that you're familiar with these conditions. Polyglandular deficiency syndrome, it's autoimmune disease, present with the subnormal function of endocrine gland. And they have type 1, 2, 3. Type 1 is quite common in pediatric patients. Type 2 and 3 present in adult patients. And this is characteristic in this case that the child have chronic mucocutaneous candidiasis and the problem with hypoparathyroid and Addison's disease. Next, we have to go fast. So I cannot do the power word in every questions. We have to go fast. All right. In this scenario, 6-month infant come to the emergency department because of seizure and have premature closure of cranial suture, markedly bow leg, and low serum phosphate, normal vitamin D and parathyroid hormone. UA show high phosphate level without glucose, amino acids, or protein. The maternal grandfather have crippled bone disease. His mother has mild bowing of leg. Which of the following is most likely diagnosis? Shout out. We cannot do power word in every questions. I heard B, and that's the correct answer. For the bow leg, you know that the bow leg is the sign of ricket, but you have to look a little bit more in detail that the ricket in this case is hereditary disease, and the most common hereditary rickets is that, in these conditions, that's the X-linked hypophosphatemia rickets, which is, as I mentioned, the most common form of hereditary rickets. That's occur because the renal threshold to phosphate excretions is low, so the child have normal calcium level with the low phosphate level, and you can treat the child. So you need to know and diagnose to give treatment to the child to prevent the crippled disease of the child. Okay, next questions. 4-year-old boy, emergency department show up with generalized tonic chronic seizure, physical exam, lethargic, temperature 37.4 of febrile, blood pressure normal, pulse 72 normal for age, respiratory 16. Oral mucosa is moist, no peripheral edema and labs. Sodium 120, K normal, chloride 96, bicarb 20, BUN 9.6, creatinine 0.4, glucose 88, urine sodium 55, potassium 16, osmolarity 530. All right, this is a little bit mistake, but I already show you the answer, right? So this is one of the common questions in every single exam for medical student, for the resident, or even the subboard. They love to ask you the SIADH. So you have to know the criteria that the patients present with hyponatremia, and the key of SIADH that despite of hyponatremia, they still have a lot of sodium excrete in the urine, and the urine osmolarity is high. So first of all, you have to approach the hyponatremia and then assess the volume of the child, whether it's hypovolemic, euvolemic, or hypervolemic, and differential afterwards. And the clue of SIADH as present in the case. The case tells you itself. That's the classic SIADH. That's the reasons they have to give you the vital sign that show that the child is, the mucosa is moist, blood pressure normal, heart rate is normal, to make sure there's no sign of dehydration, right? So that's all the endocrine. That's I try to group up all the questions together. I don't do the allergy immunology because Dr. Hiroshi did it yesterday, as I'm aware of. And some of the questions I may not cover in every subspecialty, but I try to do my best to cover things that you should know. All right, next questions. 2-week-old boy come to in ICU, and the birth weight is 1,200 grams. Ultrasound of the head revealed grade 2 intraventricular hemorrhage and periventricular leukomalacia. Ophthalmological exam revealed retinopathy of prematurity, or ROP, of both eye. Hearing screening, bilateral hearing deficit. Which of the following is the most important determinant of the child neurological developmental outcome? A, length of gestation. B, maternal education. C, outcome of maternal previous pregnancy, D, quality of prenatal care, E, socioeconomic status of the family. I want to hear the answer from the audience. That study has been done in this subject before. So in your mind, you think that, okay, maternal education should have some effect on influence and also socioeconomic of the family. That's true. But the strongest evidence is the length of gestational. So in the premature infant, just in case that gestational age is lower than 23 weeks, the mortality rate of this preemie is high. Mortality rate can run up to 85, but if the GA is above 25 weeks, the mortality rate declines significantly. And as I mentioned, some other impact influences as prenatal care, maternal education, socioeconomic have the effect, but not as much as the length of gestational age. Next question. Pregnant women come with premature rupture of the membrane. The baby born 3 days later, GA 37 weeks. APGAR at 5 minutes is 4. Lung sound is reduced. Infants appear to have respiratory distress. CBC show neutrophil 30,000. Toxic granule also recognized at the neutrophil. Gram stain of the Buffy cord demonstrate gram-positive cocci in chain. Which of the following is most likely organism? Can you just give me the answer without seeing the choice, the option? GBS, which is very common finding in the US. GBS, group B, Streptococcus. So routinely in America, if a pregnant woman come for prenatal care, they usually do like a vaginal swab culture to see whether the mother have the carrier of this GBS or not. If it is, the mom gonna get treated before delivery, and during delivery, the OB gonna give the IV antibiotic to decrease the risk of GBS sepsis in newborn. So in neonatal sepsis, you have to define whether it's early or late. For the early cause of the neonatal sepsis, GBS is come to number 1, and the rest is the gram-negative, such as E. coli. I put it long press, it should be here, and also Listeria. So treatment-wise, you give like 3rd-generation cephalosporin plus. Do you want to give aminoglycoside? All right. Next question. Is this too fast? You can slow me down because when the section go through, I'm gonna be faster and faster. That's me. You want me to slow down? No? That's okay with this pace, all right? Okay, during diaper change of 3-day-old infant, okay, noticed uneven gluteal fold. The infant was born cesarean sections due to failure of progressions. Otherwise been well. Temperature of febrile. Pulse is okay, 125. Respiratory 50 is okay. So I think that you should have familiar with all the vital signs for the newborn. You have to pick up whether it's normal or abnormal. The weight, 3.2 kilo, which is okay. Exam, left hip is more easily dislocated posteriorly with a jerk and a click, and return to normal position with a snap sound. The mother is concerned because she has a history of tetracycline use before she was known to be pregnant. Which of the following is most likely to confirm the diagnosis? So they want to confirm the diagnosis. So these questions, they assume you know the diagnosis, but what is the test to confirm the diagnosis? So what is the diagnosis? Hip dislocation, all right? So what to do to confirm diagnosis of hip dislocation? C, I heard some C. C sound interesting. Anyone else with some other answer? I didn't hear you. Somebody answer. Who's gonna pick F? Raise your hand up. All right, there's someone who answered that the ultrasound, and the answer is ultrasound. All right. Um, so in the STEM, they mentions the way of exam. I'm not quite sure that we routinely do it in Thai or not, but I'm not really teach how to do neonatal exam in Thai, but during my residency, we have to do this test all the time, the Barlow and autonomy sign, to test whether the child have hip dislocations or not. So the Barlow is the way that you try to push the head of the hip or head of the femur to out of the socket, and autonomy is you try to bring it back. So the way in and out, you hear the click or the snap, and you have to diagnose earlier to prevent the further damage of the head of the femur, and you put the hip spica on the kids. So this is the way that the child with hip spica sit. All right. Okay, next question. Term infant present with breech delivery. Complete neurological exam reveal asymmetrical moral reflex. The left arm non-reactive. The left arm fall limp, close to the side of the body, and draw upward, and the resting positions is abductions and internal rotations of the pronations of the forearm. The neonate finger show a normal response to the hand grips reflex bilaterally. Vital sign normal, no other abnormality. Which of the following is the most likely diagnosis? All right, okay. This is what they love to ask for pediatric question. Even though pediatric board, they ask these questions. All right, what's the answer? Shout out. B, right. So palsy is that the injury of the upper brachial plexus usually associated with the birth difficulty. That's the child has to be extract out of the vagina. But in this case, this is section, right? Oh, breech delivery. So it's some kind of like a retraction of the infant and probably cause the stretch over this area. All right, so you see the picture and you remember. Majority of the time, as I noticed, even though for pediatric board in the US, they give you several scenarios, but majority of the time they want you to recognize the palsy. So the sign, you just remember like the kids, the arm wise. All right, that all neonatology. Okay, next. 16 years old girl, fever, vomiting, watery diarrhea in the past 24 hours, intermittent abdominal pain, generalized myalgia, temp 39.4, BP 75/50, pulse 150. Conjunctiva and pharynx are hyperemic. She has generalized edematous maculopapular rash that spare the risk. Which of the following will be the most appropriate treatment? So they assume you know diagnosis. You have to give treatment. What is the diagnosis? No idea? Or you want to see the choice first, to see the option? So what should be your answer? Fast, fast, fast. I didn't hear anyone whisper anything. So we haven't seen this scenario at all. This is common questions, and you know that this fell into the category of adolescent medicine, which actually adolescent medicine in Thailand is not quite well developed yet. But in the US, in pediatric residency training, you have to see the adolescent, and this is their specific problem. So the condition is the toxic shock syndrome, right? Did you aware of that? So the keyword is the rash which spare the risk. So that's the keyword. And all the symptoms of shock. So this is toxic shock syndrome. And the answer is, so you know the diagnosis. What the answer? Is that what you answer? So, all right. So it's usually associated with that Staph aureus infections is caused from the toxin, and majority of the time is involved the use of the tampon. Okay. So our girls in US, majority of them use the tampon. So if they use it, have time to change that Staph aureus grow there, and then they produce toxin and cause all that toxic symptom. So the treatment, you have to remove, the treatment first, you have to resuscitate the patients because the patient is in shock, right? You have to give volume, give antibiotic, and don't forget to remove the tampon, right? Otherwise, you want to kill her. All right, next question. 7-year-old girl, okay, have that rash, malaise, and headache for 2 days. The facial rash is characteristic with slap cheek pattern, pallor around the mouth, no fever. Okay, in immune-compromised patients, the pathogens that cause these conditions may result in which of the following manifestation. So they give you the scenario that you should know what's cause of her disease, right? But they ask you, like, in the pathogen that cause her disease, if it's occur in immunocompromised, what's the conditions will cause? So this is the classic questions. They will not just give you scenario and ask direct questions. This is make the exam questions more difficult for you because you have to think twice to get the answer. So as they assume that you know that the pathogen, so can you tell me what's the pathogen? So the keyword is the slap cheek, right? Like someone slap on the child face. So what's the pathogen? I hear some whisper. Okay. So I assume that you get your answer because you're whispering to me. So what is the answer over here? What's the conditions going to be associated with this pathogen? Another whispering. Anyone want to try? I will not give you any credit. If you answer it correctly or it's wrong, I won't punish you. But help me out. C, someone try to answer C. No. Thank you for helping me out for the situation. All right, the answer is A. So you have to know the conditions. This is caused by parvovirus B19. In kids, they cause all that fever with rash, or we call fifth disease. Fifth disease in America is the way that you differentiate all that fever with rash in kids, and this is come number 5, so they don't know how to call it in the beginning. They call fifth disease, but they have also other name, erythematous infectiosum. So the child looked like he been slapped on the face, so his face just turned red, and the body they have like a lacy rash all over the body. But parvovirus B19, if it's infected in immunocompromised hosts or even those sickle cell anemia patients, they can cause aplastic anemia. So that's the answer that they want you to answer them. All right. In some adult, they may cause polyarthritis, but in adult, not in kids. Okay. Seems like I skipped some power word too. All right. These questions we're gonna have power word number 6 for the team. All right. So you can get that your box ready to answer this. 2-year-old girl come to see the doctor because irritability, crying, loss of appetite, recently have sore throat, temperature 38.5, exam unremarkable except abnormality of tympanic membrane detected on otoscopic exam. Which of the following signs, symptoms correlates best with diagnosis of acute otitis media? So they give you diagnosis, acute otitis media. So what is the most sensitive and accurate tools to diagnose this condition? Okay, ready for the power vote. Ding. I love the sound. Okay. Oh, majority of the people in the room answer A, but only 15. Huh? Oh, I'm sorry, they have just E, right? But my choice, we have F. So no one could get the right answer. It's a tricky, probably because of me. All right. So the answer is F. All right, I don't mean to disappoint you. Okay, the reasons I put these questions, this is very easy for medical students in US because their otoscope also hook up with the bulb to blow the air into the ear to see the movement of the tympanic membrane. But in Thailand, I'm not quite sure in every place, but at least Lamatipadi, they have just otoscope. They don't have that bulb to blow the air in, and not even though that the ear loop. So in US, if you train in pediatric, there's no excuse that you cannot see the tympanic membrane because they're going to give you the ear loop to clean the wax out, and you have to see the tympanic membrane of every kids that admit to the hospital. But at Ramatipadi, the resident also have excuse like we cannot see the tympanic membrane because all the wax. So, but this is just easy score for US student. But I just want to give you this thing too because it's easy question, right? You should get it easy, but somehow if you don't see it, you cannot really answer it well. All right, so I grew up as infectious disease. Okay, next question. A mother of 2-year-old boy. Okay, concerned because the child awakened at night, blank gaze, screaming in bed without recognizing his parents. This episode has occurred 3 times in the past 2 weeks. Always in the first few hours of night, the child go back to sleep and seem to retain no memory of the episode. Which of the following is the most appropriate next step in management? Okay. So they assume you know the answer and you have to manage the case. Just help me out. Try to shout any letter that you want. A, right. Okay, good. That you know the answer. So do you know the condition? Okay, it's the night terror. You have to differentiate between the night terror and the nightmare. And the night terror is part of like a development that found in a younger child. Usually start at age of 18 months and occur few hours after falling asleep, and it get better. It's different from nightmare. So this question also has been asked in pediatric board exam in America too. So you have to know differential in these 2 conditions. So the answer is avoidance of TV before going to bed may help with the nightmare, but will not help with the night terror. All right. Okay, next question. An infant come to a routine visit, exam, the infant turn when her name is called. She able to say mama. Her mother mentions she say dada at home. She's be able to look for her mother when she gets frightened. She wave bye-bye to doctor when the doctor step out of the room. Which age of this child is most consistent with developmental milestone? So this is the power word question, right? Mm-hmm. Okay, you ready for the box of the power board? These kind of questions will be asked in every pediatric question, right? To assess developmental milestone. Power board. All right. So majority of people answer E. Okay. And followed by D, dog. The real answer is D, dog, because the child can say mama, dada around age of 8 months, if you remember. So it's somewhat in between, but the closest is like 9 months. 11th month, the child development is a little bit more advanced. She can walk a little bit more and then have much more understanding that the age of 11 months of some child may close to the 12 month or 1 years of age. So this a little bit less than 11 month. So that's the answer. All right. So they will not, for the scenario, they will not give you the straight criteria that, okay, 6 months, sit without support and transfer object. They give you somewhat in between, and you have to decide which one is the closest. So that's the difficult of the question. All right, that's our child development. Okay, next. 9-month-old, chubby, healthy, appearing boy. Come to see pediatricians because colicky, abdominal pain, blood thick stool. The pain lasts 1 to 10 minutes, cause the infant double up. He then appear normal until his next colic. The infant has another episode, at which time a mass can be felt on the right side of the abdomen. The right lower quadrant has an empty feeling to deep palpations. Which of the following is the most appropriate initial step in management? So again, they assume you know the diagnosis, but you have to treat now. And this is also the question of the power board. Ready to give the answer? Get the box. All right. Majority of you get the right answer, so the answer is A, the barium edema. So what's the condition? Is the interoception, right? That the bowel just kind of like slide into the other and then cause that interoception. And the keyword is the bloody things too. But more keyword, some of the questions may give you that currant jelly stew. Currant is the fluid, kind of like a berry, some kind of like a berries group of fruit that give a little bit red color. So that's why they kind of describe as currant jelly stew, and it's somewhat the keyword for interoception too. And barium edema is both diagnosis and treatment, because when you give the barium edema, the barium may help to reduce that interoception bound to get out of the other one. All right. Okay, next question. 4 days old female infant come to the emergency department because vomiting, abdominal distension. Vomitus was green. Difficulty feeding, hard to console. Pregnancy history is uncomplicated. The infant passed meconium within 12 hours after birth. She also have small, seedy yellowish stool each day since birth up until the day 4. Exam, the child is illiterable. Anterior fontanelle is depressed. Her abdomen is distant. Which of the following is most likely diagnosis? This one will not include in the power word. You set up the power board. Okay, they set up the power board. All right. So the answer is E. So at least half of the people in the room can get the right answer. So how you know it's the midgut valvulus? Okay, the midgut valvulus comes from that malrotations of the bowel. Majority of the time, the cecum is not located in the right lower quadrant, and then they twist around the mesenteric, and the child have the sign of the gut obstruction, right? With all that complete obstructions because the child throw up with the bile staining vomitus, all right? And if they show you the film that corkscrew appearance is the characteristic of this midgut valvulus, and it's common in newborn. Okay, that's all the GI questions that I have for you. All right, we move on. Okay, next. 4-year-old boy from India present with weakness. His parents know that he's been looking increasingly pale. Hemoglobin electrophoresis demonstrate abnormal hemoglobin species. Genetic analysis indicate that the parents have the substitution of the valine for glutamine in the 6 positions of the beta hemoglobin chain. Which of the following will most likely be seen on the blood smear? So, all right. Can we do power board? Do power board,ได้ไหม? All right, so majority of you get it right. The answer is A. The reasons I bring it up because sickle cell anemia is quite often seen in the US. Majority of the time is associated with African American kids or black kids, but also Indian and Mediterranean immigrant also have the disease also. And this is a simple question that I bring it up to you, but if they want to make it harder for you, they're going to ask the complications of the sickle cell anemia. So sickle cell anemia is caused from that the displacement of amino acid. And if in case of the low oxygen state, the hemoglobin going to change to curve like a sickle cell, and then they're going to be stagnant in the small vessel, cause vaso-occlusive crisis in any organ, like the limb, hand and foot. Child may come with pain in hand, foot, and also cause a plastic anemia. It's not really. It can be present as a plastic hemolytic crisis or sequestration with big spleen. And these are the complications. So if they ask you for how to treat these conditions, the vaso-occlusive crisis, you have to give them hydrations, give them pain medications, give them oxygen. That's basic of treatment to support them. All right. So next question. 12-year-old boy come to see doctor because of pain on the right leg for 3 weeks. Pain frequently occur at night and is localized to the tibia and within few centimeters below the knee. The mother reported that the pain is promptly relieved by aspirin and the child has no fever. Exam, no tissue swelling, redness. X-ray show 1 centimeter radiolucent foci in the tibia cortex surrounding by marked bone sclerosis. Which of the following is most likely diagnosis? D. Someone answer D. We show up the answer. That's right, the D. So it's the classic thing. Usually, the case scenario like this is usually occurring like a adolescent, pre-adolescent boy with pain, and it's tragic because sometimes it's occur in the news that all that athlete at school turn out to have have minor trauma, and then X-ray turn out to have this condition. So that's the reasons why they ask quite often in the exam questions. So you have to know that this is osteoma. And I try to bring up picture. So the tibia picture is somewhat difficult to see by this screen, I think. I think it's over here. But over here is much more easier. All right. So osteoma is the benign tumor. That's the rearrange of the bone cartilage is different from normal bone. So that's caused the lesions, and it's benign. You don't have to do anything. Okay. Then I follow by this question. Okay, different age, different disease. So that's the disease of adolescent, and this is disease of infant, 1 year old child. Come for checkup, and the child has been good health, been walking for a few weeks earlier, and then he tend to bump into things and fall more than his older sister did. Family history is significant for retinoblastoma. On examinations, leukocoria on the left eye, no lymphadenopathy, no hepatosplenomegaly, normal development. Ophthalmological exam revealed retinoblastoma of the child, left eye, and nucleation was done. And the question is, this is diagnosis of retinoblastoma, but what they want to ask you is, the patient has the highest lifetime risk of which of the following conditions? They want to know the association. Your answer is? Any sound of whispering? Are there any oncologists in the room? No? So this is common question. Right now, the retinoblastoma, they found the gene that relate with retinoblastoma, and it's increased the retinoblastoma. If you detect earlier, the child can be killed from retinoblastoma. But however, the child have chance to increase the risk of secondary tumor, is osteosarcoma. So this is the thing that you have to remember. It's some kind of recall question, right? But they make it as application of knowledge. That's the way they turn the question around.
We're going to take a break for 5 minutes, and
Okay,
then
sure.
we'll wrap up
Sure.
the last part of it.